So I am indeed going to talk to you about paediatric sepsis for 6 minutes and 40 seconds. And this is going to be hopefully good fun. I'm really grateful that Prof. McManus isn't here, because this is a clinical talk. Everything else I'm talking about isn't clinical. But I'm a clinician, I'm a generalist, I'm not a paediatrician. I'm going to talk to you about two things. I'm going to talk to you about some really easy stuff. I'm going to talk to you about some hard stuff. Hopefully by the end of this you'll be a bit more cool about it. So sepsis, what do we know about sepsis? We know that in adults, think about adults for starters, that if you aggressively manage sepsis, people get better. You go back to 2001, Manny Ritter's trial, don't worry about the detail of the trial, but if you aggressively manage with fluids, antibiotics, and oxygen, people get better. It makes a big difference, and the mortality from sepsis has fallen enormously over the last 13 years. In kids, we don't have big randomized controlled trials, but we can condense the theory of what to do into things like Paediatric Sepsis 6. You've probably seen Adult Sepsis 6. It's easy. It's incredibly easy. You give oxygen, you give antibiotics, and you give fluids, 20 ml per kilo, 20 ml per kilo, 20 ml per kilo. If that hasn't worked by now, you give inotropics, you give adrenaline. That's it. Okay? Everybody happy with that? That's awesome. Bit of a loss now, because it's quite easy. You spot sick children, and then you give them 3 things, and they get better. So that's the end of my PK talk. Or it would be, because that's the easy bit. The easy bit is really easy, and you know this from your adult practice, but what's hard about it? Or is it hard at all? Well, it seems to be, because you audit whether we do this, and this is the 2009 audit of UK practice. They miss those targets, those really easy targets, in 60% of kids. So we're clearly not doing what's easy, and there must be a reason for that. We're not stupid, you're not stupid, we know what to do. And interestingly, these kids are in your department for 7 hours, they're not on the PICU, so this is a responsibility for us. So is it just frequency? Is it because we don't see this very often? And there is some truth in that. This is a study from this year looking at 270,000 admissions to PEDs across Europe, and only 176 of them had severe sepsis. That's not the same as in adults. We see sepsis in adults all the time. So think about your familiarity thing. Is it a difference thing? Is it because kids are completely different? You've done APOS? Chapter 1, children are not little adults. Possibly the most dangerous phrase ever uttered in paediatric medicine, because it paralyzes people. And it gives you the impression that they are so completely different that you can't treat. And what I'm going to try and tell you today is that you should look for, yes, there are differences, particularly in neonates, they're weird, but look for the similarities. And think, why is it we're scared? Okay, yeah, go there, we've said that. It is high stakes, dealing with kids is stressful, so we're a bit unfamiliar with it. We can't change those, but we can change this issue about people telling us to be scared. And think about transferability and what you know from your adult practice into paediatrics, which you don't see very often. Because as you walk through the door of resus and you see your critically ill or critically injured child, just ask yourself, what's completely different about how you're going to resuscitate them? What's totally different? And the answer is not a lot. In fact, arguably, very little indeed. So, what are we going to do? What other things can we think about? Well, we can think about the initial assessment phase. That can be a bit tricky, Children, a hot, miserable child can look sick. But we do have objective scoring systems, so you probably use EWS in your practice, the early warning scores. There's a paediatric version, so use that. There's a great thing here, Spotting the Sick Child, which is online access. You can go and learn, or you can teach your colleagues about how to spot the difference between somebody who's miserable and somebody who's irritable. Really good stuff. This is my reminder slide to remind you that children are not human. Neonates are not human. Okay? They're weird. Don't deal with neonates. Well, what else? We're going to hear more about neonates later. Access. Why are we getting these targets? It's probably about getting intravascular access. It's difficult. Nobody's as good as they think they are about getting intravenous access in children. And you've probably seen a small child being held down by 9 people, 2 per limb to frantically ream the veins, whilst one person holds their head. It's bad practice. And in our practice, Natalie May talks about this, one of my colleagues, you have 2 good goes at getting venous access by somebody who knows what they're doing. If that doesn't work, you give an intraosseous. Her tip, I like it. Give the intraosseous to the nurse, and she gives the option. You either put the intraosseous in now, or I'm going to put it into you. That seems to focus people's minds. And we think that's a good practice. And they're very good at disciplining us about that, because I'll always get the next day, except I won't. Then what are you going to do? You're going to give some drugs. Can you remember the formula for a 7-year-old weight? No, you can't. Nobody can. It's a completely waste of time. Under pressure, nobody can remember formulas in the bottom of their head. It's really difficult to remember things like wet flag or wet fag, the APRS formulas. You just can't do it, so don't. Use something like crashcall.net or one of the many apps around there, which will calculate your drug doses for you. I gave a 10 times the overdose of insulin to a 1-year-old 10-kilogram child. I can assure you, you don't want to do that. You really don't. So use support. This is freely available. There are others available. No, I'm only interested in it. Okay, and then you're going to give some fluids. Fluids is awesome. We said before you're going to give 20 ml per kilo, 20 ml per kilo, 20 ml per kilo. And if that doesn't work, we go on to inotropes, which is adrenaline. Very, very straightforward. Reassess the patient after each bolus. And that's the equivalent of about 5 litres in a 70 kilogram bloke. So it's quite a lot of fluid. But they do need, these things need it. And obviously if they're going to inotropes, they're heading to PICU. Bit of controversy about fluids. Most of the protocols will say give saline. Saline's fine. The most important thing is you give volume, you give fluids, and you give it early. We've moved to more balanced solutions like plasmide, like Hartmann's in kids. And that's quite good. You don't get the same chloride load, so they don't go quite as acidotic, which is good. But it's a bit debatable. Some people think it just increases your chloride, but it doesn't make a difference. The last point, just to return to this concept. Are you waiting and not treating your sick and injured children because you think that there's somebody else out there who's better at it than you? Are you waiting for Superman or Superwoman to come through the door? And if you are, kids aren't going to do well, and they probably don't exist. You've got huge amounts of expertise in adult medicine. Huge amounts of expertise which you can transfer to kids, and if you do that, you'll make the what easy, because it's the same. And you'll make the how slightly less hard, because you just need to think through a few of those tips and tricks, and your kids will be good. Thank you for your time.